45 degrees, but now it is quite usual.
Oh my God, yes, yes, the world is changing so much. I heard that in Saudi Arabia it's snowing.
Yeah, do you want us to send you some heat from here?
With that heat, it will be water by the time it reaches.
But here at high altitude, during the winter, we have the most beautiful blue sky, a beautiful sunlight. So during the day, it's very pleasant and very beautiful.
You are too lucky, you know, in view of us, you are not living on the globe anymore, you are on the moon.
That's right.
At that high altitude, because you don't sense the pollution, you don't sense the real temperature that normal people are sensing, no oxygen.
Less number of molecules in the environment. So
no pressure, nothing similar.
Yes, Professor Gustavo. Yeah, I was busy with making it live stream of YouTube. It is now live stream. So I was busy with that. So I welcome you, Dr. Gustavo, at a long time, but not that big long time. But we are once again here in the appropriate platform, the scientific platform in the world of medicine. And along with us, Professor P.S. Shankar is there, and who was actually in his 60th teaching as a teacher of a medical school, 60th anniversary. You are one of the guests along with Paolo Pelosi. So he is here with bless us. Professor Hamid is there. Dr. Shangram, the professor of medicine from MR Medical College, Gulbarga, also there. So I'm able to reach somebody, and our today's host to conduct the interview, Dr. Vidya Patil, professor of anesthesiology of B.M. Patil Medical College, BLD University. She's also here. So I'm just waiting for another couple of seconds. Then officially I will start the program. Right. So Professor Pelosi, I have made you co-host, right?
I made you?
I have made you co-host. Means you can upload. I have given you all permission from Zoom. If you wish, you can upload your slide. Whenever you require, you can upload from your end, or you just tell me, I will upload from my end.
No, but I have some. I am trying, but I have some problems in the
leave it.
How the computer is organized.
Okay, leave it.
Better that you upload.
I will do it from my side. No problems. So I just, with the permission of Professor Hamid Mobashiri and Dr. Gustavo Zubieta, on behalf of the UNESCO UNITWIN network, and today is a great day, the July 1, 2022. Because in India, in my country, it is celebrated as National Doctors' Day. So this is a right an opportunity to celebrate in a great way. So we have decided to have an interview this time with another legend who fought for COVID-19 and whose immense contribution in medicine as a professional as well as a researcher made the world in a different level. So we invited Professor Paolo Pelosi, Chief Professor of Anesthesiology and Critical Care Medicine, University of Genoa, Italy, today to be a guest of our program. So Professor Paolo Pelosi has been kind enough to accept our invitation and to be honored as a guest of honor of this program. And with this, I also thankful to Dr. Vidya Patil, Professor and Head of the Department of Anesthesiology, B.M. Patil Medical College, BLD deemed to be University, also to accept, we accepted also to be the host of today's program to have an interview with Professor Paolo Pelosi. So this program will be, first I will request Professor Vidya Patil to take over and do the needful. So she will introduce Professor Paolo Pelosi to the guest, followed by a series of questions she will be asking. And in between, Professor Paolo Pelosi, when he feels that he wants to show the slides, he will go for the slide. He will be telling us to upload the PPT, what he has sent to me. 5-6 slides are there in appropriate time. He will be requesting, and I will just upload for my end. So this is the end of the program, end of the interview. Professor Vidya Patil will, thanks to the all audiences, and hand over the mic to me. So we will confer the certificate, the honor of UNESCO UNITWIN Network under Dean of Environmental Health. And then we will be asking Dr. Vidya Patil also to be given the certificate of recognition on behalf of the UNESCO UNITWIN. These are the official formality. In between, before we confer the certificate, there will be open program discussion. So today's, those who are panelists, the guests from distinguished professors. So first, the questions will be asked by Dr. P.S. Shankar sir. He will be first asking his query to Dr. Pelosi, followed by other physicians, Dr. Gustavo, Dr. others, Dr. Sangram Biradar, all will be asking. And then public, Dr. Hamid Mubashiri will be lastly. Dr. Hamid Mubashiri will be presiding over function. So he will give a presidential remark at the end, and I will conclude the session. So this is the program at nutshell. So without delay, I request Professor Vidya Patil to take over the mic and start today's curriculum, a great event of National Doctors' Day of India, interview with Professor Paolo Pelosi, life and works of Professor Paolo Pelosi. Let us start here only. Thank you very much. Over to Vidya.
Thank you, sir. A very good evening to everyone on this virtual platform, and a very happy Doctors' Day to all the doctors on this platform. It's indeed a great opportunity for me to be the moderator of this event, and I'm immensely thankful to Professor Kusal Das, Distinguished Chair and Professor in Physiology of BLE University, Vijaypur, for the same. My sincere thanks to the Honorable Vice Chancellor of our university, Dr. R.S. Mudor, and respected Principal, Dr. Arvind Patil, for their immense support. I take this opportunity to also immensely thank Synerik Arepetan and Hamid Mubashiri and Gustavo Zubita for convening this program and also for being with us on this great day. Let me at the outset delineate this stupendous personality called Paolo Pelosi, Professor Paolo Pelosi, the distinguished guest and pole star of today's event, before the actual conversation with him. Currently, Sir is Chief Professor in Anesthesia and Intensive Care, and he's also the Director of the Specialty School in Anesthesiology at the University of Genoa, as well as Head of Anesthesia and Intensive Care Unit at the San Martino Policlinico Hospital for Oncology, Genoa, Italy. This biosketch of Professor Pelosi is in fact a simplified, brief account of his illustrious academic journey. To tell you the truth, I really had a tough time concising his biosketch to this level. Professor Paolo Pelosi grew up in Milan and graduated in medicine and surgery from the University in Milan. He completed his studies as specialist in anesthesia and intensive care, and then as research fellow in anesthesiology at the University of Milan. He served as associate professor in anesthesia and intensive care medicine at the University of Insubria, whereas from 1999 to 2010. He has always been active in both clinical and research fields. His main research interests have been respiratory physiology during anesthesia and respiratory failure. Professor Pelosi developed several collaborations with scientifically reputed groups in European and other countries for research in the field of mechanical ventilation and sepsis in experimental and clinical settings. In this line, he promoted the constitution of the ProNet Investigators Group, a large network of researchers worldwide. Along with them, he organized large-scale databases, carried out observational trials and randomized control trials, focusing on protective ventilation and its effect on outcome measures. He has been an indispensable member of the team in a number of meta-analyses that have been carried out in a number of large prospective randomized control trials, as well as observational trials, which aimed at discerning respiratory physiology and pathophysiology in patients requiring mechanical ventilation due to various reasons like ARDS, bronchiolitis, and bronchial asthma. He has served as the president of the European Society of Anesthesia and has been instrumental in development of different national and regional guidelines for improvement of clinical management of critically ill patients. He has been a secretary and then the head of the Respiratory Intensive Care Assembly too at the European Respiratory Society. He has also served as the director of the Department of Anesthesia and Intensive Care and the director of the Regional Poisoning Control Center at the San Martino Polyclinic Hospital for Oncology, Genoa. He has served as a member of the council at the World Federation of Societies of Intensive Care and Critical Care Medicine. In this, he contributed to the development of WFSI CCM recommendations on triage in intensive care unit, which also deals with the ethical issues of critical care to a great extent. He is the president of Italian College of Professors in Anesthesiology and Intensive Care and member of board of the Indian Society of Anesthesia, Italian Society of Anesthesia. He was also editor and co-editor of several books and scientific issues. He is actively involved in the fellowship and resident educational programs at the University of Genoa. He instituted and implemented European Diploma in Anesthesiology and Intensive Care in Europe. He has been instrumental in introducing innovative teaching methods that use simulation techniques. We all know about the famous Helsinki Declaration of 1964, which deals with the ethics related to duties and responsibilities of doctor researchers towards the safety and well-being of the patients. This declaration was instituted for the first time after the Second World War. Prisoners were cruelly used and exploited for researches and studies involving live human bodies of the patients. This Helsinki Declaration is periodically amended. I feel proud to say that an anesthesiologist was one of the 3 signatories of the amendment, which materialized in the year 2010, and he is none other than Paolo Pelosi, sir. During his tenure as president of the European Society of Anesthesiology, Professor Paolo Pelosi developed with others several innovative programs. Like a research committee was formed, which constituted of international investigators to collect large databases and design observational and randomized control trials and to bring about more evidence-based practice in anesthesiology. Secondly, a guidelines committee was also formed to develop and institute guidelines to homogenize the clinical management in Europe and the world outside. Fellowship programs were initiated to provide opportunities to young residents in anesthesia and intensive care. Specific training programs were also conducted for the residents on patient safety measures in the perioperative period in less economically advanced countries of Europe like Moldova. Sir is author or co-author of 497 original papers, of which 173 papers under invitation. His H index is 73 Scopus, and he has 27,457 citations to his credit. He has authored 121 chapters, 72 proceedings, and has made 264 presentations at meetings, and has lectured in more than 1,500 national and international meetings. Paolo Pelosi Sir's researches involve issues like, firstly, the analysis of computed tomography of the lungs in ARDS, which markedly contributed to the development of protective ventilation strategies. Secondly, clarification of the changes that can be brought about by prone positioning and the net effect on lung recruitment in ARDS, and identification of those patients who can benefit with this therapeutic strategy. Clarification of the concept of primary and secondary ARDS, which contributed to the change in approach to ARDS. Then also in research to understand the interaction of brain with other organs of the body so as to develop therapeutic strategies in patients after cardiac arrest and brain injury. Evaluation of transpulmonary pressure by using esophageal pressure in patients undergoing mechanical ventilation during anesthesia and critically ill patients. This methodology has now been recognized as an important tool to optimize mechanical ventilation in patients with ARDS. Optimization of the ventilator settings during different types of assisted ventilation in ARDS and acute exacerbation of COPD. Understanding of the respiratory changes during anesthesia and in the postoperative period of morbidly obese patients. This was important to improve ventilator strategies during and after surgery in high-risk obese patients. Evaluation of postoperative pulmonary complications and resultant mortality. This study markedly contributed to recognition of differences in the perioperative outcome of patients receiving defined care either before or during or after the surgical intervention. Development of the concept of protective ventilation during surgery to improve outcome. Development of non-invasive ventilation devices to comfort patients with respiratory distress, in particular, studies about the use of helmet in different clinical conditions, like particularly in infants with bronchiolitis. So the academic and research pursuits of Professor Paolo Pelosi are exemplary, and it's our good fortune that he has agreed to be the chief guest and spend his valuable time with us today. Now that we know so much about his work in the academics, in anesthesia, also in research, I would like to ask him to throw more light on certain issues, certain aspects that I thought would need more clarification to me and my faculty and my postgraduate students. Sir, to start with, shall I start with the conversation, sir, the interaction?
Yes, yes. Thank you, Dr. Vidya, for excellent introduction, because this is an interview. So one must know who is the guest. So in depth of his work, because we are all medical faculty and science faculty, researcher and scientist and professor and resident students. So you should know it. So Dr. Vidya elaborately some of the important works only added in this to understand a nutshell that what Dr. Paolo Pelosi is. But it is very difficult to explain Dr. Paolo Pelosi in such a short time. You did a marvelous job, Dr. Vidya. Please go ahead with a formal session.
I totally agree with what you said, sir. It is really very difficult to understand a personality like Professor Paolo Pelosi, because he's worked so much. I mean, his works are so voluminous. It's difficult to explain how much he has contributed to anesthesia and intensive care. So coming to the conversation, the questions that I would like to ask him. To start with, sir, your biosketch says that you recommend and promote protective ventilation in patients who have ARDS and postoperative ventilation as well. And in both the situations, you prefer to give protective ventilation. Could you, for the benefit of my students and myself, could you please elaborate and tell us what exactly is this protective ventilation?
Thank you very much. First of all, thank you for the invitation. It's a real honor for me, for so many friends, and now we know each other.
Yes,
The different meetings together, and especially this last year. And also very honored to share with you it's not really my experience, it's an experience of a trip, that I had since I was younger till now. Yes, we developed this concept. The concept of protective ventilation was developed mainly for RDS patients. So for patients who had severe lung injury. And this came from the CT scan that you mentioned before, in which we showed years ago that the amount of aerated lung in RDS or severe hypoxemic respiratory failure was reduced. And that's why it was named also by my former chief, Professor Gattinoni, as baby lung. So it's a smaller lung in the original lungs. And from these images, the concept of protective ventilation was developed, which means to ventilate, so to give tidal volume, tidal breath, according to the dimension of this aerated lung. In other words, if I have a mice or a mouse, we have a small lung, so we have to give a lower amount of tidal volume in order not to stress and injury the lung. If we have an elephant and there we have
tidal volume is high enough.
The lungs are very big, and of course the absolute tidal volume will be much bigger in the elephant compared to the mice. But if you standardize the amount of the tidal breath and pressure, the tidal breath in the elephant and the amount of tidal breath in the rat is exactly the same for the normal lung. So this is the same when you apply for a patient with respiratory failure. You can imagine that you have a lung from an elephant, which is a sort of the original dimension of our lungs. I am, of course, transferring the idea to the lung of a mice or a mouse, so much smaller. So we have to reduce the tidal volume. The second point is that if we ventilate in pressure and not in volume, this is easier because, of course, we have to avoid excessive inspiratory pressures. We know that when we perform an inspiratory capacity at the maximum volume, we reach around 30 centimeters of water in the transpulmonary or airway pressure is a little bit higher. So if we ventilate at the maximum inspiratory pressure, not above 25, 27 centimeters of water, which is exactly the same of pressure that we reach when I reach here the maximum total capacity, we are at the upper level of safety limits. So ventilating in pressure control as compared to volume control is much more safe and easier to be targeted in terms of protection. The third point is related to the amount of what we call positive end expiratory pressure, the so-called PEEP. This is the pressure that we can apply at end expiration to keep the lung open. And this is the amount of pressure we learn that has not to be excessively high, especially above 15 centimeters of water, because this might produce an excessive static stress of the lung at end expiration. So we learn that it's not good for the lung to be continuously maintained open, fully open at end expiration. The other point that we learn in this very recent year is the role of respiratory rate. We believe that the amount of respiratory rate was not so important to determine lung injury, while in the recent years, we clearly found that the increased respiratory rate for the same amount of protective ventilation in terms of pressure or tidal volume was associated with an increased risk of lung damage. So we have to be careful also in the setting of respiratory rate during controlled mechanical ventilation. Overall, this concept has been translated to the amount of energy which is given by the ventilator to the lung, and the terms of mechanical power, which is the amount of energy delivered, which depends on the tidal volume and the pressure, but also the respiratory rate to the lung. And impressively, we found that not only lung injury patients with lung injury, but also non-RDS patients, more or less they follow the same rules. So if we increase the amount of mechanical power delivered by the ventilator to the lung, we increase the risk of lung injury and worse outcome. And very interestingly, another parameter, which is also called the driving pressure, which is the difference of pressure between end inspiration and then expiration. So it's the driving pressure during the tidal breath, might be even more important than tidal volume per se. That is why, because if you remember, the formula of the compliance of the respiratory system is given by the tidal volume divided the driving pressure to deliver the tidal volume. So the driving pressure is equivalent to the tidal volume divided the compliance. If you assume that the compliance is associated with the amount of the aerated lung, as I told you before, the driving pressure is an extraordinary parameter to be set and targeted at the bedside, which give us the information of the amount of tidal volume related to the amount of aerated lung. So it was called the strain of the lung, tidal volume divided the aerated lung. So driving pressure is very important for protecting mechanical ventilation and should be always maintained below 13 centimeters of water. And is even more important than to decrease the respiratory rate. So we learn a lot of things, but let me also add another point. All these concepts that started from intensive care due to the treatment of patient with severe hypoxemic lung injury, we shifted to the patients in operating room, so patients more or less with what's called healthy lungs, and in non-RDS patients in ICU, and they refer to patients after cardiac arrest, as you mentioned, neurologic patients, or post-operative patients, which are even the majority of patients in the ICU, which has not RDS, which is a sort of rare disease, apart from COVID, which was an extraordinary, terrific situation. So we moved the same concepts to the operating room and to the non-RDS. And impressively, and one study will appear very soon in a very big journal, even in cardiac arrest patients, we found that protective ventilation was associated with better outcome. And this was clearly shown in several randomized controlled trials that we performed during anesthesia. So the final message is that protective ventilation for all mechanically ventilated patients is not more something it started from RDS, but now we know that the same rules, of course, a little bit adapted, but more or less just the inspiratory pressure, but all the other parameters follow the same rules, should be used in all other patients. Of course, if we move to assisted mechanical ventilation, which is not controlled mechanical ventilation, it's possible that some different parameters should be considered. It is more difficult to measure the driving pressure. Really, we can do with some occlusion, with some particular. Now we have to move towards protective mechanical ventilation, also in assisted ventilation, which is not actually so considered. So I think I tried to summarize the importance of ventilation, and which is very cheap. So it's cheap. It does not require money. It does not just require a decent ventilator, not top-class ventilator, a decent ventilator. It requires knowledge and brain of the physician and healthcare professional, and require observation to the patient. So that's the message. It's good for all countries in the world, from more rich or less rich. If you use protective ventilation, what I say is the easiest and cheapest way to save life from operating room to the more severe RDS.
So in a nutshell, to summarize what is protective ventilation, it would be something like which has a very less maximum inspiratory capacity, less optimal inspiratory capacity, and then the PEEP is at its lower ebb, and then the driving pressure is also taken care of.
Yes.
Isn't it, sir? And then I would like to ask one more thing in this. What about the inspiratory expiratory ratio, sir, the timing?
Yes, this is an issue which was investigated many years ago, and this was mainly by Professor Lachmann in Germany, that he proposed the inverse ratio ventilation. So to keep the inspiratory phase longer than the expiratory phase in order to increase the mean airway pressure in the lung, in order to keep the lung more recruited. For this reason, the idea was to minimize the amount of atelectasis and to minimize the opening and closing of this area and lung injury. However, recent data suggested that yes, you can use not inverse ratio, but in my opinion, but maximum 1-to-1 ratio in the very early phase of ventilation, keeping the inspiratory pressure, as I said, maximum 27 centimeters of water, with protective ventilation and moderate level of PEEP, but not exceed the 1-to-1, because this might be associated with too much increase in mean airway pressure, and this might have negative effects on hemodynamics sector, which is not usually so much considered. So, and when then go back to 1-to-2, so more physiological inspiratory ratio as soon as possible, which always is better in the winning phase. So I think that we changed our view. In the past, we were convinced that higher pressure recruitment or mean airway pressure was much better to open up the lung, and it was associated with reduced lung injury. Now we know that yes, we have to keep some sort of mean airway pressure in the system, but we have not to exceed, because we know now that even the static, so at end expiration, higher mean airway pressure may produce lung injury. So we say that now we promote the concept of a sort of permissive atelectasis, of course, within the maintaining a permissive lower level of oxygenation. Low is so I would be more cautious to increase too much the mean airway pressure in our patients.
Okay, sir. Sir, moving on to the next question. Your research includes work on deciphering the complex functioning of the brain in the patients with cardiac arrest and brain injury. We follow the recent guidelines of CPR brought about by the American Heart Association, AHA guidelines, sir, which is updated and revised periodically. Is there a difference between what is proposed by AHA, American Heart Association, and what is practiced in Europe? Is there a major difference?
So I think that you have to divide two issues. One issue is related to cardiac arrest, are the ventilatory support, respiratory support during cardiac arrest. And this is almost no difference compared to, I think, all over the continents. There are even no major difference between the American Heart Association and the European Resuscitation Council recommendation. One question is related to the amount of inspiratory oxygen fraction, but I think the data, actually there are some large studies ongoing, but I recommend to use anyway high FiO2 in that set. Much different. So which is one of the problems? That most of the attention was focused on the reanimation phase. And most of guidelines, they focus on that, which is of course very important, because we know that time is gold in this section. We know now even that cardiac massage is even more important than alveolar ventilation. But it's a completely different setting. When you get the ROSC, so you resuscitate in sort of hemodynamics resuscitation the patient. And what we found was this is a very important phase, which is not very much considered in the current guidelines. what we found, and this is a study that will come out very soon, that when we analyze the data from the large hypothermia study, the TTM1 and TTM2 trials, and we look at the ventilation, it's the first time that we specifically look at the effects of ventilation, which were the best target in terms of pressures, in terms of oxygenation and outcome of patients. What we found impressively was that protective ventilation, exactly with the concept that I showed you before, played a major role to determine not only outcome, so what I mean survivors and not survivors, but also with neurological outcome, which is even more important. So just use protective ventilation after resuscitation, which was not very much considered since few years ago, or few months ago, we found was extremely important to improve survival, but not only to improve the neurological outcome of patients who survive. The second point is related to the gas exchange. Of course, the guidelines, they were focused on the fact to optimize the level of oxygenation. That's why they suggest to use higher oxygen fraction during resuscitation phase. But what about oxygen targets when the patient is resuscitated? We found two things. We measured also the brain oxygenation and the systemic oxygenation. First of all, the systemic oxygenation not always reflect the brain oxygenation. What I mean is that if you have a relatively normal or high PO2 effect ratio in the systemic gas exchange, you can have almost 40 to 50% of the patient with lower PO2 threshold in the brain. So you believe that you are giving oxygen enough, but this is not the case when you measure in the brain. In fact, we found that when we look at the oxygen relationship with outcome, mortality or neurological outcome, it is like a U-shaped curve. But this U-shaped curve was much less wider, so more straight than we believed before. What I mean is that we found that oxygen target below 70 to 80 millimeter of mercury in the systemic oxygenation, so not less than 60 as we believed before, were markedly associated with reduced mortality. And on the other side, we found that oxygenation above 160, while it was considered above 300 before, is associated with worse outcome and neurological outcome. So we should keep oxygenation within a much narrower range, between 70 to 80 to maximum 150 or 160, compared to what previously believed. So that means that we have, it's not a question of high or low FiO2, but it's a question of to target individually the amount of FiO2 to the amount of oxygen. The other issue is CO2 is not very clear. If we have to, of course, we know that we have not to maintain PCO2 below 30, 35, because this might be associated with vasoconstriction and possible regional ischemia. But the question is, if we keep CO2 a little bit higher than physiological and we can allow a little bit more vasodilatation, might this be helpful, especially after cardiac arrest or not? There is one large study which is soon, which clearly investigated this specific topic, and we will see the results. We have some data, but of course this has to be approved in this study that we just be. So it's possible that we can keep a little bit larger range of PCO2 or not in the next future. As I just, the third point is the hemodynamics. We know now that we have to maintain a certain amount of higher level of linear pressure when possible after resuscitation. So we should maintain above 70-75 mean arterial pressure in order to be associated with better outcome in our patients. So you see, we have to combine three factors that were not much considered in the current guidelines. First of all, protective ventilation when we resuscitate our patients. Second point is to maintain oxygenation within very strict targets, and so individualize FiO2 according to the saturation. Third point, to maintain a moderate level of mean airway pressure, but above the conventional level, eventually by the need of noradrenaline in the early phases after resuscitation. So I think this is a new view, not only a resuscitative period, but very important early after resuscitation to improve outcome in this patient. And again, what I am suggesting is not cost expensive, is just looking at the patients and use very easy and cheap methods to personalize treatment.
Thank you, sir. Moving on to the next question, sir. Your work involves clarification of the changes that can be brought about by prone positioning and the net effects on lung recruitment in ARDS, and also identification of those patients who can be benefited with this therapeutic strategy. Sir, tell us more about it, and also about how would you decide which of your patients would be benefited by this strategy?
Prone position, again, is another strategy that started from CT scan observation. You know, when the first CT scan showed in RDS patients mainly densities in the dependent part of the lung. Impressively, when we turned prone the patients, at least in some patients, part of this density almost disappeared or were reduced in the dorsal part, and oxygenation improved. But then we learned more. The prone position is associated with a more homogeneous distribution of the pleural pressure. So when we give again a protective tidal volume, this is more homogeneously distributed across the line, from non-dependent to the dependent part of the line. So we moved from the concept of prone position, just improve oxygenation and we are happy for that, to a sort of additional protective ventilation, because the distribution of stress is more homogeneous. That's changed our philosophy of prone position. So to apply prone position very early, first, because you apply very late, of course, the lung is more fibrotic. It might be helpful in terms of reduction of ventilator-induced lung injury, but less effective as compared to the early phase. But secondly, as a sort of additional protective ventilation. So to be maintained for a longer period of time. That's why now we promote prone position for at least 17 to 18 hours a day. And even in COVID, some teams proposed to maintain for 24 or 48 hours continuously. We turn all patients in which PO2 FiO2 is below 150, and in those patients in which we require a level of PEEP higher than 15. These are the patients which turn the patients. Usually you require 2 to 3 prone positions, so 2 to 3 days. And we maintain prone positions again for at least 17 to 18 hours a day. Several studies showed that if you use this technique, it seems to be associated with better outcome. And however, the mechanism leading to the improvement in prone position may be different. In RDS are mainly related to recruitment of atelectatic lung regions. In COVID-19, we found that it was more related to the redistribution of perfusion. So less effect on the lung, more effect on the perfusion. So in COVID-19, we have to be, I'm not saying that prone position is helpful, it's very helpful. But especially in awake patients with COVID-19, prone position should be performed if required, but very carefully monitored, because the improvement might be just symptomatic. So you have an improvement in oxygenation just to a redistribution of perfusion in most of cases, and not recruitment on alveolar collapsed lung. So this may delay the intubation, because you have an improvement in oxygenation, which is not due to a real reorganization of the lung structure, just symptomatic, and you delay intubation. This is not good in COVID-19. We know that when you need, you have to intubate patients with COVID-19. So be careful. I'm not saying that in a awake patient, this has not to be used. This is a very good rescue maneuver, especially if you have many patients, but has to be very careful monitored, and there's not, in my opinion, to be prolonged too much time if it is not associated to a real improvement in terms of lung function. But prone position is a standard of care in our experience, and I believe that, of course, you need healthcare professional, physician and nurses, physiotherapy, well trained for that, because remember, this might be associated with pressure source, possible neurological lesions, especially in the eye. You have to be very careful. But most importantly, if you have a cardiac arrest or other problems, you have to be ready to act immediately. So it's a maneuver that has to be always performed by trained healthcare professional under careful monitoring, and in order to avoid the possible negative consequences.
Yes, sir. We do require more help if we want to put a patient in prone position, especially in COVID situations. It's difficult to get that help, sir.
That's why in COVID-19, we probably prone less, also because we prefer to use a sort of permissive epoxy in these patients. And on the other side, we have to be very careful in COVID. That's why the reason we maintain the prone position for even longer period of time, to avoid too much movement. Might be the risk of other complications. So anyway, prone position is also associated with more use of neuromuscular blockade agents. That's why we have not to use for more than 1, 2, 3 days. In COVID-19, it was associated with corticosteroids. So, you know, corticosteroid and neuromuscular blockade agent, it's not a good combination. So I like prone position. We promoted prone position worldwide, but is a maneuver that has always to be performed with strong physiological and clinical background, especially in COVID-19.
Yes, sir. Sir, could you please tell us about your approach to the management of ventilation, be it perioperative or in the ICU, in obese patients?
Yeah. This is one of my love, because one of my first papers when I was younger in 95, where I think the first paper on mechanical ventilation and people in obese patients. At that time, PEEP was not used in operating room. There was not much attention, even at the specialty school, was just of course, the pain control, anesthetics, but no mention at all for ventilation. Ventilation was just the green target on the ventilator, so with a fixed set point without any rationale or discussion, while the targeted ventilation was just for RDS in intensive care. So only intensive care physicians were the people who were managing the ventilator. In anesthesia were just the use of anesthetics, but not the use of ventilators. Wow, just I was coming from anesthesia, then intensive care, anesthesia now, so very broad experience. So we try to move the concept of intensive care to operating room, and especially obese patients. And what we were impressed by the fact that, as I told you before, protective ventilation was very effective also in operating room. And this was done more or less at the same time with our colleagues in France, from Emmanuel Foutier and Samir Jabert. And we did not know that we were working more or less on the same topic, but impressively, in 2-3 years, around 2013, so very recent story, no more than 10 years, In 2 independent groups, we found the same result in terms of protective ventilation during surgery, and this, I think, changed, in our opinion, the story of anesthesia and the story behind ventilation. In obese patients, so we know that we have to use protective ventilation. We just completed several studies. We know that even higher PEEP, again, the same story. We were supposed that very high PEEP in obese patients were more effective. We have another study that will appear very soon from Probese trial that up to 12 to 15, we don't get too much. So you can start with relatively low level of PEEP in obese patients, no more than 5 to 6 centimeters of water. You have not to exceed recruitment maneuver that we believe in the past, because they are not so effective, just for a few minutes. Only in patients in which you observe a progressive deterioration, you can a little bit increase the PEEP. But this is a minority. We found only 15% of the patients that did this. But what we found that in obese patients, especially, almost 30% of the patients may have a hemodynamic negative effect. So we have to be very careful, even in obese patients, to exceed in the amount of pressure, but we have to be very careful to monitoring hemodynamic monitoring, which might be affected in these patients. So more or less, even obese patients may have benefits from traditional protective ventilation as other patients. A different story is after extubation. After extubation, we know that most of these patients, mainly patients who suffered of OSA, so sleep apnea before, or they have higher PCO2. Higher means higher than 50, really, if the pH is higher than 45, 50, mainly 50, 55, they might benefit of a sort of few runs of positive pressure after surgery. And especially what I mean, I think more carefully monitoring. I'm not saying in the ICU, but in a sort of subintensive intermediate care for 24 hours, 48 hours. In those patients who not all obese patients, in those patients who deteriorate saturation or increase respiratory rate more than 20 to 25 after surgery, or they have a story of OSA or hypoxemia or higher PCO2. These patients should be monitored for 24 hours, 48 hours in a sort of intermediate care or in better monitoring areas in the ward. This means to me the concept of perioperative, to introduce the concept of perioperative medicine, that we have to look at the patient before operation, so of course to evaluate his clinical status. We know now that we have to be very careful, be very gentle in the ventilation surgery, and to have appropriate hemodynamic monitoring if required. But also, the story is not finished outside the operating room. The story in most of patients, and the obese patients at high risk are particularly important, may be also 24, 48 hours after surgery. And again, this is a sort of organization. I know that might be difficult sometimes, but this might avoid complication. We know that postoperative pulmonary complications are around 10% of the overall population of these patients, and may reach up 15 to 20% in morbidity-based patients with previous. So if you are able to avoid complication, again, this is better for the patient, is better for their family, and is also better for the healthcare system. So this is something that the management, I don't know your experience, but the management, it's difficult to explain because they just look at the moment. They don't look what can happen, what you can prevent. Can I make a comment on robotic surgery and laparoscopic surgery? Also,
go ahead, sir. Yes, sir.
Laparoscopic surgery is very clear also from our data in perioperative. It's very important. So it's the best way to reduce complication. Of course, if you have not complication, but it's much less. Regarding robotic, I think that is a different story. You know that robotic now is becoming more and more popular all over the countries. I'm not against the robotic. We published 2 studies actually showing that complications are quite high in terms of pulmonary. So that does not seem to be less than laparoscopy in other terms. I think we have to learn more on to optimize mechanical ventilation during robotic, because you know the time of surgery is longer, positioning are different. Our data suggests that the longer time that you need for robotic, especially when you increase the type of surgery, these play a relevant role. So may overweight the possible advantage of robotics. So we have to learn much more about robotic. We are just at the beginning. And we have to learn more on the fact that to do robotic, we need surgeons that are as fast as possible with robotic. So my message is that our data suggests that robotic may not be so much better than laparoscopic, but is much more expensive, we know. If the duration of robotic surgery is too long. So I understand that the training time that we need for everyone, but we have to consider that the time of surgery during robotic may play a major role. So we need surgeons that becomes very, very expert in robotic. So the issue of robotic is open, and I think will be a very important area of research in the next future, not only for surgery, but also for perioperative and anesthesiological management.
Moving on to the next question, sir. So we understand that COVID-19 created a devastating havoc in Europe, as it did in many Asian countries as well. What has been the experience of anesthesiologists over there, sir, in Europe? And what were the issues that you had to confront as anesthesiologists?
So you mean in terms of organization of?
Yes, sir. What problems did you face, sir? What were the factors that you had to confront as anesthesiologists?
Anesthesiology.
And also as
yes.
organization, as your hospitals and others, how they feel the difficulties all together.
Yes. The first of all is the shortage of anesthesiologists. In Europe, we have a shortage of anesthesiologists. This is due to different reasons. First of all, because now the anesthesiologists, they are becoming the reference of everything in the hospital. So because they're becoming the people who are more similar to a sort of acute internal medicine. And so while in the other areas, they are becoming super specialized. So they are asking a lot of things, sometimes even more than we are able to do. The second, from operating room to intensive care or emergency in the hospital, like that. So I think that this has to be changed. So we need some support from outside. So if you have a surgical ward, we need also physicians from the surgical ward that then can solve at least 70% of the problem. And it cannot be just need the anesthesiology with one code. On the other side, so extremely large interest for anesthesiology in intensive care. I think this is good, but we have to change the mentality in the hospital and also of the management, because the management, they don't understand sometimes that, except in the acute phase or like in the pandemic. The second point is that the anesthesiology is not very appealing for the young generation, because, you know, this depends on country to country. But if you have not much private activity, at least in our country and in other countries in Europe, especially if you work in intensive care, it's a very hard job, 24 hours a day, 7 days a week. The professional recognition are not so high, even in the hospital. You are always good where you are in the emergency, but you are the ghost when you have no more in the emergency. I say that the anesthesiology is the ghost, no, but you are always there. And this is not good. So the young generation, yes, we have younger colleagues that they approach anesthesiology and intensive care, but they are coming from different experiences. It's not always the first choice. So I think we have to change the paradigm. We have to change the paradigm in the manager. We have to change the paradigm in the healthcare organizers. They have to understand that anesthesiology and intensive care physician, they play a major role not only in the hospital, but also in the healthcare system. Now we have pain service, people on the ground, so many things. No? We became more recognized during the pandemic, but even not so much as we expected. You know that almost 75% of COVID were treated by anesthesiology intensive care, the real severe ones. But then they have, with all the respect, the pneumologists, infectivologists, like that. Yes, pneumologists, they give a major, but I'm not saying that infectivologists are there, but I mean, COVID was a clear example that there was no role for a infectivologist. It was an infectious disease without any treatment. It was just a supportive treatment for, but this was not very, but with all my respect, for sure. But even in this condition, we have seen in our society, Italian society, yes, but if you ask the people who is an anesthesiologist, it's one guy or a woman or maid that anesthetize, that make you to sleep, but they don't know what you are. And this is now we have to change the paradigm. I say to the Italian society, I will be the next president, I'm the vice president actually. We have to change with the media. We have to change with the new media form like YouTube, LinkedIn, Facebook, Twitter. We have a different approach. Why? Because the anesthesiology started as an individual profession. No, you are in the operating room alone with your tube, your mechanical ventilation, and your patient. That's it. And when you finish the operating room, your job is finished. Now we are talking even today about the perioperative medicine, intensive care. Anesthesia is not only the 1, 2, 3, 4, 5, 6 hours in the operating room. Anesthesiology is a more complex view. If we enter in this concept, we can probably change the image of anesthesiology in Europe and worldwide. And I think the scientific society in Europe, we have the European Society of Anesthesiology Intensive Care, the American Society of Anesthesiology, should play a relevant role in that. They should, the World Federation of Anesthesiology, they should talk more each other about the lifestyle. I gave a lecture years ago at the European Society of Unity, anesthesiology as a lifestyle profession. As I say, anesthesiology, in my opinion, is not a specialty, it's an attitude. You have to be, you have in your mind to be anesthesiologist and intensive care physician. And if you are not, it's better that you choose another, because it's a different specialties for us. I'm not saying it's better or not. I'm saying that requires a lot of passion, a lot of sacrifice, a lot of different thinking compared at least to some other specialty in the medical field. And sorry, we have to start also education from the medical faculties. Because if you, in most of the countries, including ours, you don't talk about anesthesia, you talk about emergency. But you don't talk about anesthesiology or intensive care during the Faculty of Medicine. And also we have two things. The woman, very important. Imagine that if you have almost now 65% of women in the medical faculty, you have almost 80% of women in the anesthesiology. Very important. So we have to change the organization of work because, you know, we have to approach differently the organization of work. And the organization are not prepared for that. And the second, younger people. Are women and young people. This is the next generation of anesthesiology intensive care physician. And if you have young people, the education, the cultural tradition, the new education of the young people is not like of my age. I'm not saying that now I'm becoming old, but it's different in terms of private life, private life and public work. The time for your life, the interest, the connection is different. I'm not saying it's good, is better or not. It's different. So we have to plan an organization of work in the hospital, and I can say also sometimes outside the hospital, but I work in the hospital, because we have more women and of course young people, which means also younger women. So we have to prepare for that. Otherwise, we can face important problems in terms of organization and in terms of healthcare system in the next future. But I'm so happy to say that in my uni, the leadership is a woman. In the academic, we have not many because the positions are not many in academic, but are half and half. Young. The average age is actually around 47. So that's the future of anesthesiology and intensive care.
So in my department, 50% of the faculty working is ladies, women faculty.
Yes,
and
yes.
Yes, sir. And the changes that you just now said will are difficult to come about, and they will certainly take a very long time, sir.
Yeah.
There has to be a change in the mentality as well, sir, of everyone, including the.
And I can tell you even more. I had some conference on that because both in the European Society of Anesthesiology Intensive Care and in the National Society and in our university, we are doing a lot of work for this question of. I don't like you are good or not. No, you are professional. Not. But we are trying to understand better how to improve the quality of the woman job, no? Because this is the problem. Independent of in male and female, you can good or not professional is not a question of, I don't know, we call in Italy, quote rosa, so pink area. This is like the reserve. This is not the good approach, in my opinion. And it's offensive towards the woman, in my opinion. So we are discussing this issue, however, the good thing is that since we have, I think will improve in the next year because we have more and more younger females that are approaching academic and also our specialties. So we will go in this direction. However, we found that sometimes female women. They are not culturally prepared to become the leader of or in the academy. That's the point. We discovered that sometimes if you ask to part of them, so we did some surveys, and interesting at the European level, it was the female sometimes, okay, I prefer to do another thing than this. And this is, I think, is an educational issue. So we have to start again from probably even before, but from the university, that the woman has to change also herself. Sometimes I understand that there is a problem, but we also found that something is an issue that has to be improved within the woman and also men, because now with the young men we have other problems. So I think is an interesting point that we have to discuss all together in the next future. Also, the families. No, I mean, it's a
complex matter, sir.
It's a complex matter. No? What happens in the family? If you have a family that is so it's a complex matter, and I think we are just at the beginning. And remember, it's not only a female problem; it's also a male problem. If you look at the young generation of males, it's not like in the past, and so what we call the millennials, no? The millennials generation, they have a different attitude, and we have not to say, we were better because we were years ago. No, we have to interpret differently these needs, which are very similar, male and female. So that's my point is also that probably in the past, in the future, will not be anymore a question of gender. No, we have the gender equality plan in our university. Will not be gender in terms of female. No, gender in terms of male, female, in terms of generation, not gender equality plan, but generation equality plan. So just to look at the future.
Yes. Moving ahead, sir, as an experienced senior physician who has witnessed many upheavals in the healthcare during such major outbreaks like this COVID pandemic, what do you think are the possibilities of occurrence of another big wave of this pandemic? What do you think, sir? Will it occur? Do we have to be prepared for it? According to you?
I think that with COVID, we learned many things. First of all, we learned that to have a healthcare, I'm not talking about the overall system, I'm talking about the hospital response, otherwise the discussion will be too long. So in terms of healthcare system, I have some ideas, but it's not my job. What about the hospital? We learned and critical care and anesthesiological critical care. We learned one thing is that we should abandon the architecture of different small ICU. If you have large areas for critical care patients, it's better to manage because you have a better organization of healthcare professionals. So I think that we have to change on how we have to build up our hospital. Big areas and not small areas with the same competence. Of course, these are some political issues, but these are another. Second, we learned that at least, I'm not because I am an anesthesiologist intensive care physician, but the anesthesiology and intensive care, like in Italy, we have the same specialty. Okay, we have the same, then some more work in that, on that. But at the time of emergency, we had a very big interchange. So our colleagues for operating room came to ICU, of course we had, but there was no problem. And we were able to maintain operating room. So we're very good interchange. So I don't think, second message, that to have a lot of super specialties, independent, not super specialty, independent primary specialty is good for the future. We learned that we need people very interchangeable. Then you can have a super specialty, but then overall you need a common area of interest. Second point. The third point that we learned, I think, is that we have to be prepared in terms of clinical treatment, but also organization. For example, we learned from COVID that it's not only a question of critical care, but also after discharge of the ICU. So we learned that it's not only critical care unit, intensive care unit, but it's a question where we discuss intermediate care, subintensive care, whatever you call it. Subintensive care, I don't like sub because it looks like, I like more intermediate care. And I think that most of hospitals are not prepared for that. They have no intermediate care plan. Even our hospital, we are doing something, but we learn, and we learn was essential to discharge a patient not directly to the ward, but with the intermediate care under our leadership in that case, we avoided almost 95% of complication when patients were discharged. So I think that the third concept is that we have to promote the concept of intermediate care, which may be helpful for patients from outside, but also patients from the ICU, and then moving up. The fourth thing that we learned is the follow-up of the patient. We did not make attention to that. So for us, again, everything was finished when the patient were outside the ICU. No, with COVID, we learned that the patient may have a problem even at discharge of the ICU, of the intermediate care, so when he's going back to the ward, or even after hospital discharge. And that's why we created a sort of ambulatory follow-up of critical care patients. And this, I think, is something new. Other people that are doing that, but it's not so common. It's difficult. It requires passion, dedication, not much money, of course. But this, I think, is very important from a social point of view, because we realized how many disabled patients we are creating. We are happy when we have patients discharged by the ICU, but now we have to take care of the quality of life of these patients. We have to take care of the families of these patients. They may have major problems. We never realized how much problems we may create. We can create very good things, of course. We saved a lot of lives, but also, and this is something that we have to pay for that, we also create some problems, bigger and smaller. But we have to monitor that and we have to be prepared for that. But the management, the healthcare people management, they have, of course, a lot of attention for many other diseases, which are also for historical point of view, but they don't care about this kind of patients which are discharged. And as I used to say, we have to become physicians that families and patients have never to work alone. This is what the fans of Liverpool Football Club are used to say, no? And that they're not families and patients. No, it's, we will never work alone. And I modified in patient and family will never work alone. And I think that there are no better than anesthesiologists, intensive care physicians that feel the real difficult moments. Also, when you have donation or donors, no, to have this role in the next future. And but this again has to be developed.
Sir, now this question has nothing to do with academics and research. Sir, I would like to know, do you have any real time for yourself? Do you have any hobbies? Your time?
This is a very good question. I can tell you the truth. When I was younger, I was a very good ski, and also swimmer. I also was the professional, but at quite good level. I also played tennis and like this. However, with years, I had much less time for myself. I also play a little bit piano, I play flute. I like to read, especially historical books. And so I have many hobbies. But I can tell you the truth, more you have responsibilities, less time I have for myself. Fortunately, I have a very good family. My son is now in the United States, he's in engineering. My wife, she works in Milan, I work in Genoa. I have a great support from our families. So anyway, I was very lucky to do my life. Because I was surrounded by people that my wife, my family, now they died, but my wife, my son was very good. So I can say I was lucky. But I can say that if you tell me did you pay some price to get what you are trying to do? Because I really believe in my profession, not for myself. My teacher will used to say, you get what you pay. It's true. But I do that because if there is even one person that tell me, Paolo, you did something for us, I am happy. This I reach my goal. I know, and I'm very happy for that. Many people are. And for me, it's great. But I can tell you, this was something that I lost in my life. But it's not lost, because if you do things with passion, dedication, we have many friends all over the world. I try to support them when they have difficulties. They support me when they have difficulties. This is the world that I like, without borders. So for sure, I lost something perhaps, but for me, it's not a loss. When I will retire and I will be in good health, I will do again. I know how to play, not as in the past, but I know anyway. Don't forget, I know how to win, to play. No problem for that. But I think, and I tell to the young people, sorry. It's probably other people, they think different. But if you want to reach top targets, you see for the people at the Olympic Games, now we have the World Championship or like this. This is the people that spent most of their life on that target. So if you want to reach a top target, there is no chance. All the people that I know, they spent a lot of time. This does not mean that you have to organize in the right way your family. This does not mean to forget the family. This means that you have to organize, and this depends on the different situation, the right times for everything. It's not easy, but for sure, if you want to reach a target, this is my teaching for young people. You need to invest a lot. It's true that you don't get all what you pay, but this is for sure. But if you don't pay anything, you will never get anything. And let me conclude with one sentence that I always say to my students, but it's a philosophy of my life. It's coming from Tiziano Terzani. He spent many years in India, and he was a great journalist in the Vietnam War and whatever. Then he died for a cancer. He changed it. This is from one book, one section that I like very much. He said, when you are in the mountain, no, in the hills, and you have two paths, no, one going up and one going down. If you're going down, you are safe. You know that you reach a small village. You know what you get. But in your life, and that's what I did, I teach my students, is my philosophy of life, what I taught in my family. If you have the possibility, take always the pathway that go up. You don't know if you get something. You can have clouds, you have fog, you have difficulties. You don't know if you reach the top of the mountain. But you have a hope, you have a dream. And to me, and this is also for our Italian society, for our, I think that the most important in life is to have a dream. It's not important if you get or not, but you need to have a dream. And I think that this is the most important way for our life. And if you have a dream, there is no problem for whatever can happen. If you have less time to play or less time, you know that you are doing sometimes something more important. This is, I try to concentrate in a few words, really in the deep of my heart, my philosophy of life, and I will never change for anything.
Very inspiring, sir, indeed. I just hope all of my students listen to this part at least, hopefully. Now, coming to the end of it, sir, you had some slides to show us. Do you want to go ahead with that?
No, don't worry. I told you what with my words, which is even better than what I wanted to present in the slide.
Okay.
Do you like to show, Professor Paolo, or
No,
you
no,
don't?
no, no
No
problem.
need. Oh, that's
I
fine.
told by voice what I wanted.
Yes, yes, you have given extraordinary. Yes, Dr. Vidya. Thank you.
Okay,
Dr.
sir.
Vidya.
Thank you, sir. Thank you, sir, for being with us and answering all our queries. It was really a wonderful conversation that I had with you, sir. I cherish these moments, sir.
Thank you.
Thank you.
Great
Thanks a
honor
lot
for me.
For being with us.
Thank you. Thank
It's
you.
a pleasure, and because I like very much to talk about these kind of things, which is not science, but what is behind science, which is not behind science,
Yes.
which is behind an experience. And I think that it is always lovely to share your experience of life, which does not mean that it's the best, but this is something that can be shared with other colleagues.
Yes.
So thank you, sir.
Thank you. Thank you, Dr. Vidya. And thank you, Professor Paolo. Professor Paolo, there are some people who will be asking you some small question, 1 or 2 questions will be asked. So
Yes.
kindly be with us. I first request Professor P.S. Shankar, who has completed 60 years of teaching in medical school and honored by UNESCO. And Professor Paolo was there, one of the
I
guests.
know him very well.
Professor Shankar, 2 listen, one from India and one from Italy. Now they're meeting with each other, one from internal medicine, other from the anesthesiology and critical care medicine.
Sure.
Let us see that what exactly going on now. Professor P. Shankar.
Professor Pelosi, we have a wonderful time over about the last 70 minutes. You have taken us from the protective anesthesia to prone ventilation, prone position, then robotic surgery, then you took the other things, your hobbies, interests, everything. When I came to know that you are from Milano, I went back my memory to 1982, when I was in Bellagio, the Heaven on Earth, for 1 month as a Rockefeller Scholar in Residence to write a book. So you have said there are certain instances where we say, now the patient also is participating in the decision making about the treatment. So along with the physician, patient also is participating. There are some situations like coma, or person is on ventilator, where the patient can't participate in the decision making about the treatment. But their relatives play an important role. So now let us say a person is on ventilator and the physician knows it is futile. He will not recover from that. But the relatives will be insisting that we must continue that one. So there is a situation where to do or not to do, continue or not to continue. When will the physician, as the anesthesiologist, if you are under the patient is under a cure, when you will definitely tell them, though it is not palatable, for the attenders, you have to tell that stop this one, we'll discontinue, because there are many court cases also. But as a physician, when will you advise them to discontinue the ventilation?
Yes, I mean, this is an issue that, of course, we discuss. The point is the following. First of all, there are some, I can tell you about Italian legislation. If you are in coma, so you as a patient, you cannot, the family has not the power to decide in place of the patient. However, you have to hear the family and especially the willingness of the patient before, unless the patient has written before something. Now there are some more regulation for that, but of course it's always difficult. But if again, I think is a person. Most important is the relationship between the physician and the family. And I am back to the points that I discussed before. If the physician starts to have a very good empathic relationship with the family, it's very, very difficult that you can reach different views in terms of what to do to the patient. So this is why, because we have a great experience when we are talking with for the donors, no? And now we have also the donors at with the beating heart, and so the question to me again, yes, you can regulate with laws, whatever you want, but the most important is the relationship between the physician and the patient and the families in that case. And this is another point that is not much considered. The time that you have to spend with the patient, if it's possible, of course, to have a relationship, or the families, which is more common in our case, unfortunately. But this time is not considered a sort of working time. It's considered wasted time, while to me it's very important. It's more important to have half an hour more to talk with a family, and you get much more in terms of results. So anyway, in Italy, if we decide that the situation has no chance, we discuss with the family. Of course, this has not to be done from 1 minute to another. This has to be prepared. That's why it takes not only half an hour, 1 hour. Sometimes I stay 3 hours to talk. If my colleagues have not much time, they come to my office. You see this one, and we talk each other. I hear. I don't speak too much. I just want to hear. The silence is another point to me. In the past, the religious men, whatever religion it is, they knew what it was silence. Now silence, we are not used to anymore to be silent and not to speak too much. No, today I spoke too much, but we have to learn now to hear the people, to listen to the people. And in that case, I think we can solve almost 95, 97% of the cases. So it's a problem, but I think it's more a problem of relationship.
Fine.
That's my point of view.
Thank you. Thank you.
Thank you. Thank you, Professor Shankar. Thank you, Professor Paolo Pelosi. And now I request Dr. Shangram Biradar, the Professor of Medicine. Professor Biradar, would you like to ask any question to legendary anesthesiologist, Professor Paolo Pelosi?
Thank you, Professor Das, for an excellent opportunity given. I also thank Dr. Paolo for his excellent interaction. My point of care is there were a lot of issues, literature flooded for the use of lung ultrasound, point of care ultrasound. How beneficial was it for you people? Because Italy was the worst hit country, though initially it could not get materialized.
If I can tell you the truth, now ultrasound, then we can talk not only lung. Ultrasound machines now. When I arrived here in Genoa in 2010, there was only one small ultrasound machine, small like this, really, in one hand, and not perfectly working. So I introduced the largest, that was from Philips, there is not now, we have another one. So anyway, big companies for ultrasound. And now we have 4 or 5 machines in the unit. So I think that ultrasound, whatever it is, point of care, emergency, intensive care, and in my opinion, in the next future, operating room and especially post-operative period has to become a standard. So I think now there are different curriculums, but this has to become a training in the young resident for anesthesiology and critical care, and not only, I think, emergency, internal medicine, and so on and so on. Second point, I would say not only the lung. Now we're doing a lot of cerebral monitoring, a lot. We are also center for teaching for that. The heart, we do, it's very important. We have cardiologists there, of course, that support us, but of course the basics we know. For thrombosis, the checking of thrombosis. The abdomen is more difficult, I can tell you. But for example, central vein, in terms of volemia. So I think that ultrasound, the optic nerve sheet, so a lot of application. The movement of the diaphragm, the thickness. So in one word, if the question is, should we invest in the ultrasound for critical care and not only, my answer is yes. Is ultrasound only for the lung? My answer is not. We should have some knowledge, perhaps some groups more for that, the other, whatever, also for the main of the other organs. Then you have the super specialist, but as an anesthesiologist intensive care, I think now it is included in the curriculum of the residency period. And you don't need a very expensive machine. With at least in euros, I mean, with 20,000 euros, you can buy a good machine for these purposes.
Thank you, Dr. Paolo Pelosi. Thank you, Dr. Biradar, for excellent interaction. I now request, before I conclude, going to the presidential remark, I now request Dr. Gustavo Zubieta. Professor Gustavo.
Thank you very much, Kusal. I think you have chosen the right man to give a focus of mechanical ventilation, and this benefits over 1.2 billion people in India. This knowledge that Paolo has given us, which is great wealth in science, it benefits the ventilation aspects of so many people. You know, I have found your presentation, Paolo, very interesting. We call the lungs the pneumodynamic pump, as you recall. And normally, when the ventilation is spontaneous in an organism, in our beautiful organism, it's a negative pressure, biologic, autosufficient ventilation, which has its own biofeedback mechanisms to the brain, and it is naturally limited. This means you cannot breathe too much to hurt your lungs. But when you do mechanical ventilation, you do exactly the opposite. You don't have a negative pressure, you have a positive pressure mechanical ventilation, and power is limitless. This is like a powerful Ferrari car with an extremely powerful engine that is in the hands of the anesthesiologists. And you can burn, I mean, you can accelerate, move the knobs, and really destroy alveoli. So your work has been very clarifying, I think extremely important. I hope it has been recorded and anesthesiologists around the world.
So Gustavo, you are saying that I am trying to reduce the power of the Ferrari.
Yeah, that's right. That's right. You are doing exactly that, you know, and but your work is truly magnificent, and you have learned through experience to be more conservative. Now, my question for you is, as I was telling you, our systems protects us biologically through biofeedback mechanism with sensors in the lungs. Do you believe that future mechanical ventilation equipment will have other type of sensors in the lungs so that it informs the anesthesiologist that there is a stress failure in the lungs? Maybe the technology will evolve to that level. Another point that I want to mention is that I am amazed at you because you are on to the next. I think Paolo Pelosi will be known for this expression, on to the next. What this means for all of you around here is that he finishes a paper, works very hard, full of details, scientific details and so on, but then immediately he's working on another. He never rests. Do you ever sleep, Paolo? This is my question. And finally, well, please answer those, and then I'll talk about the 8 chronic hypoxia symposium.
Yes. No, regarding to the next is fun. Gustavo knows. So when we get this was because I was working with actually also with a friend in Dresden. Now he's working in Cleveland, Professor Marcelo Gamba de Abreu, and he started years ago when we worked together since more than 23 years now. And to say at one paper he said, okay, to the next. So when we started as like for the lucky, and at the end of each paper accepted, I write again to the next. And if you, and these are the magic words, because if you don't write this, it's more like when you are in Rome and you have the Fontana di Trevi, you know that you have to have your shoulder back and then you have to send a little money if you want to come back to Rome. It's more or less the same. But now it's becoming more and more. So the magic word that should be very few people should know that. Now they know much more. So I'm worried because now even more people, but this is also good because this means that more people can publish. So this was just a joke, but it's real. I always write to the next one. Now even more people, they write that. So it's becoming more worldwide. It's not like for a few. Regarding the monitors, this is a very important question. I think that the idea is great. Just at the beginning was the NAVA system, no? Which was a sort of control from the electromyography of the diaphragm. But of course, this is just one, because as you mentioned, and then we have the different sensor in terms of gas exchange, stretch receptors, many other things. So probably it will be very complex to put all together the signals and then to have a feedback. We have to learn much more. We even don't know, as I told you before, which is the best. Probably the threshold of oxygenation, CO2, pH are different in the different critical conditions. So we almost don't know anything about pathophysiology in these patients. So we just know 1%. And we know that it's not possible to transfer what we know from traditional physiology to our patients. We know that the threshold are different, the interaction are different. I told you before that oxygen in the brain is not systemic. So more you monitor and more you see that is more difficult and unexpected, and you can explain why something that we believed was good for the patients because we followed the traditional, the traditional physiology was not good for the diseased patients. So, but I think that this is very important for industry. This is open another issue that we need much more link with the industry, but not that the industry develops something strange. So just briefly, what I think actually, which is the system, that the industry developing whatever monitor or strange things, and then they ask to the physician, now we have to see if the thing is good or not on the application, whatever. It should be the reverse, that we start from some very strong physiological ideas and then to test. The second point I think which is not good is that most of these tools are implemented before we know exactly how they work. No? We will never do that with a common drug. We will never give to everyone a drug if we have not tested with different tests. No? While for mechanical ventilation is different. You can do whatever you want, you get the approval, and then it's in the machine, everyone can do that. And then you have meetings that you have to discuss if this kind of ventilation is. We were discussing before, no air ratio like this. We don't know even know anything about that. Just if we improve oxygenation or not, that's okay, yes. But we know that sometimes if we improve too much oxygenation, we have even worse outcomes. So if we can follow even the wrong companies, no? So I think we have also in this field, so interaction between physician in this field and industry, probably we have to modernize, to be more innovative and to have a different approach. But I think it's something that we have to think in the next future, to have more information and to have a automodulation. We are trying to do something now, you know, on how to reduce the driving pressure automatically, the PO1 like this, but most of them are individually targeted, and I don't think this is the right way. Probably it's more combat with artificial intelligence. For example, I think we can get new horizons, perhaps in this particular field.
Yes. Thank you, Paolo. And now let me just very briefly mention that we are carrying out our 8th Chronic Hypoxia Symposium on October 10th to the 15th here in La Paz, Bolivia, a magnificent city where chronic hypoxia is the main theme. And as Paolo very well mentioned, you see, you don't need to give too much oxygen. At sea level, the idea is that you have to give a lot of oxygen, and this is truly a mistake. And we live in little oxygen, and we learn more and more that hypoxia can be even beneficial in chronic hypoxia. So this is being organized also by UNESCO and UNITWIN, thanks to Professor Cusaldas and Professor Sinerik and Professor Amit, the Bolivian Army, the BLD University, University of Laval, Universidad Tomás Frías, and Zubieta University. We're all working together to make this a very successful meeting, and we invite you to join. Some people from BLD are going to be present and to give their talks, and it's an itinerant symposium. We start in La Paz at 3,500 meters, and we move on to different places, and we continue the talks. It is extremely interesting, and I hope you all join us, and we enjoy the learning with people like Paolo. Paolo, by the way, please send me again the title of your talk. Thank you very much.
I send to you. I will resend. I send to you.
Send it. Yes. Thank you very much.
Thank you. So thank you very much, Professor Gustavo. Thanks to Professor Paolo. It's an excellent interaction. And I think that we have learned a lot in today's program from Professor Paolo Pelosi. His interaction with Dr. Vidya Patil. I must really appreciate Dr. Vidya Patil for selecting the questions where it started from the science, core to the medicine, then the practice and ethics all together. She ultimately lead to the personal liking, disliking, and his own choice, passion, hobbies in this regard. It's an amazing interview. I think Professor Paolo must have enjoyed. And this is in YouTube, so I will share you the link. And I request Professor Paolo to share with your Italian society and European society and everywhere, and also Dr. Gustavo and all the professor here, including I request respected Honorable Dr. P.S. Shankar sir to please share the YouTube link with the medical fraternity to know about the perception and ideas and thoughts and the vision and mission towards the anesthesia and critical care medicine as per is very required for the 1.2 billion population, as Dr. Gustavo mentioned, in India. Very much well. I request Dr.
Send me the link so that
I will send you. I will send you the link. I request Dr. Sangram Biradar also to do the same needful. And I now really appreciate both of you for taking time and having so much of time. Professor Paolo, in spite of your busy schedule you have taken to be with us and make us enjoy it. And a lot of students were there. They enjoyed your talk fully. And I hope then YouTube, much more people will be now listening, and they'll be hearing, they'll be watching. And this will be a ready reckoner for a medical sciences, for history, for one of the legendary, I can say, the anesthesiologists and critical care medicine specialists, where persons like Dr. P.S. Shankar, Dr. Gustavo, and all legends are also available here. Thank you very much. And I now request Dr. Vidya Patil to hand over the certificate, the honor, to Professor Gustavo Zubieta. Hello.
I'm fortunate enough to be doing this honor. I take this opportunity and present this certificate to Professor Paolo Pelosi with all due respect and utmost humility. Please accept it, sir.
I shall send the certificate PDF to Professor Paolo Pelosi by email in the right detail.
Thank you.
Thank you very much. I now request Dr. P.S. Shankar virtually confer the certificate appreciation to Professor Vidya A. Patil, Professor of Anesthesiology, BLD University.
I'm very happy to present her this particular recognition, which she has done, but very excellently she conducted this particular program.
Yes.
And I definitely tell with all my Dr. Vidya Patil has done a wonderful job. All our best wishes to her. And I request that let her continue this particular program in future also.
Thank you, sir. Thank you, sir.
Thank you very much, sir. Thank you. We are really honored. So this. Before I conclude, I now request Professor Hamid Mubashiri, Professor of Biophysics, University of Tehran and UNESCO UNITWIN Network Coordinator from Iran, and Regional Coordinator of UNESCO UNITWIN Network, to give a few presidential remarks, his valuable presidential remark at the end. Over to Professor Mubashiri.
Right. Thank you very much, Professor Das and Professor Pelosi, for great talk of your experience and then the great activity that you did in the medical departments, and my colleagues there in BLDE for the questions and others. First, I'd like to know, as a biophysicist, I'd like to ask you two questions, possibly very quickly. First of all, you know that this mechanical ventilation did a lot of damage because it wasn't set properly and lots of people suffered from it. So is it possible to replace it somehow, first by a system that conducts the real nerve signals to the lungs, so that the patient can somehow sense the feedback, the biofeedback that Gustavo was properly mentioned, so that the lung cannot be damaged as such? And the second thing is it possible to train the patient instead of using the machine, the people who are not in unconsciousness condition, to do some exercises, even though if they are in the CCU or intensive care, so that they activate the way the lung acts, so that the situation becomes better? And the last is, how is it possible to have the ventilation to replace the air in the lung and somehow filter it out of the virus or whatever it is, or set the humidity or the pH of it so that it can cope with the infection much better, instead of using the mechanical or artificial system?
So regarding the first question again on the monitoring, yes, there were some attempts. For example, this neural-assisted ventilation, which will take in the signal of activation or the electrical activation of the diaphragm. And the ventilator, there are only one ventilator is doing that. So again, it's not so commonly used, available, because it depends which ventilator you have. However, I would like to stress one point, because yes, even if you have all this signal, the question is that is not true, because we are convinced that if you have a signal from the gas exchange, the brain, the diaphragm, whatever, our response is the same as we are in a physiological condition. The problem is that when we have lung injury, for example, all the signals that are coming to the lung, from the lung to the brain, are completely altered. And the risk is that the signal that we take, we believe that they follow more what the patient wants. But in reality, they give a feedback, even a worse feedback, because, for example, if the patient is, okay, now I want to ventilate more, but does not mean that they like to ventilate more. For example, in the COVID was a typical example. If you have a patient with COVID and it was maintained for a very long period of time, not intubated, the patient started to ventilate more and more. This, of course, is a physiological response to reduce the PCO2, to increase the alveolar PO2, a little bit better oxygenation, and so on and so on. But from the lung was not good. It was better to rest the patient, to intubate, and I give you the rules. Because it's true what Gustavo was saying, okay, we have a Ferrari, we crash, but the Ferrari, we can also move faster or less faster. So that's what we have to do, not to take the Ferrari and start at 400 kilometers per hour against a wall. We have to modulate the Ferrari. If I am driving, it's not my case. The Ferrari is in the city, in the town, or if I am on the racing in Monza, okay? So the question is that the concept is not so true that if we get this whatever signal we get, and we have a feedback on the ventilator based on our knowledge on physiology, this is always good for the patient, first, in terms of critical infections. This is first. So we have to learn more. And I think that, again, artificial intelligence, in my opinion, might help us perhaps to learn about more in this very complex world, which is more complex than normal physiology. The second question was regarding the activity of the patient when the patient becomes more awake. Yes, this is an issue that is related to respiratory physiotherapy. This is a forgotten area. I mean, we have a respiratory physiotherapy, but in many ICU are not present. I think, yes, that early mobilization, incentive exercise like this may help. But again, in our world, it's more difficult because if you start too early, it may be even worse. If you start too late, it's worse. And you say, yes, you have to start in the right time. You have also the slide. The problem is that you never know which is the right time. So again, even respiratory physiotherapy is good, but we don't know exactly how much dose, when, in which patient, when. So the problem is that we are a specialty of medicine that is full of unknown, is full of our thinking, is full of physiology-based rules transferred to the patient. And the problem is that what we have found, and protective ventilation is an example, is that, you know, we believed that you have to keep the PCO2 at the physiological level. We have to keep the oxygenation at the physiological level. But we learned that is not correct. Sometimes it's better protective ventilation to have higher PCO2, to accept lower level of oxygenation than but less airway pressure in the lungs. So these are just few examples related with what we discussed, that our world is very different from other areas of medicine, in which we have very clear protocol for cancer like this. We are very much advanced in terms of diagnosis, even now, genetic diagnosis, molecular diagnosis, very, very targeted drugs. No, we are in a completely different world. And even I don't know if there was a discussion, if we apply this so much personalized to our field, are we going well or not? Because when we have a cancer, we have that cancer, okay? That typology of cancer. We have not a disease, we are not treating diseases in most cases. We are treating syndromes, which are a cohort of symptoms, a mixture of disease. We are not treating one disease, while medicine was born to treat one disease. So even personalized medicine applied to our field is not so easy as we believe. So, I mean, it's a big challenge. The third was about humidification and possible contamination. Regarding COVID, I can tell you one thing that we learned. Well, of course, if you have open tuberculosis or like this one, has to be a bit more careful. But if you are very well covered, so very easy, so FP2 plus surgical mask or a shelter or whatever, just not like an astronaut. We learned that to be like astronauts, you know, the white helmets are not helpful, just only to lose consciousness of the healthcare physicians or nurses. So very simple method. We never got any people infected in the hospital. We got people infected outside, but in the hospital, very difficult. So I think that even we were very worried, you know, about a non-invasive system, a high flow system like this. We treated patients with and without boxes, no problem for that. So probably because also the system of cleaning system were efficient, I don't know, but So this is another myth that I think we have to. This does not mean that we don't require not to be protected, but not too much. Even here, less the minimum is more.
All right. Thank you very much. Indeed, on behalf of UNESCO, I mean, as a coordinator, I would like to thank you for your dedication. And you talked about your personal life that is completely dedicated, apart from the youngsters when they're skiing and then doing other skiing and so on. But everybody will, I think, appreciate the amount of time and effort of yours, the one that was applied in Italy, as well as the knowledge of yours, which was spread all over the world, and everybody learned about it and people benefited from it. I hope the moral of the cooperation and collaboration serves the situation in a way that such a thing never happen again, and no pandemic, no epidemic, nothing at all happens, and hope everybody comes together to stop it in the first place when it is a matter of the infection is and a matter of the control of the different microorganisms in the first place, so that people can live in peace and in healthy condition. And somehow, instead of this problem that we have, they deal with the more friendship and peace and good health, and to make the world a much better place to live with, the place that we haven't found a similar one yet in the universe. So it's well worth it to take care of it in every level, in terms of the infections and in terms of the morality of all people. And this session that Professor Doss arranged with his colleague is greatly appreciated, because it strengthens the friendship and cooperation from east to west, from the India where East to the Bolivia to there. And people, you with your busy time, I know in the hospital, Professor Gustavo, early morning, and other colleagues of ours that I can see that number of people are participating. It is their dedication to participate in this session for the sake of better life for all human beings on the globe. Thank you very much indeed. And I really learned from your talks and appreciate it very much. Thank you.
Thank you.
Thank you. Thank you very much. Thank you, Dr. Paolo. Thank you, Dr. Vidya. Thank you, Professor P.S. Shankar. Thank you, all the distinguished guests, my friend, Dr. Biradar, Dr. Gustavo, and all. With the permission of the President of today's function, Dr. Hamid Mobashiri, I'd like to conclude the session here and going off for the session. And so I wish you all very happy day or night or evening, and goodbye. Keep a good health.
Thank you very much.
Thanks.
Ciao. Bye-bye.
Goodbye, everyone.
And to the next. Ciao.
Thank you, Arnaud. Thank you.
Ciao. That's it. Bye.